All right, welcome back. Now let's get back into our discussion on Tales from the Front Line as we seek to find out just what the case is in our COVID-19 wards and in how our health workers are grappling with this impending third wave. Let me reintroduce my guest once more, Dr. Rowena Njeri. She's a medical superintendent at the Kangema Sub-County Hospital in Muranga, and Dr. William Muriuki, who is a medical doctor working at the Nyeri County Referral Hospital. Thank you both for staying on with me. Dr. Bill, let me begin with you because I've seen this come up a lot in conversations, be it with colleagues or with friends. A lot of reports of people self-medicating at home when they get a few symptoms here and there. And then next you hear they move on to get hospital care when things kind of get dire. And literally within days, they're no more. For you as you're taking in patients, what kind of symptoms are you seeing, and are there any new ones emerging now?
Victoria, it's actually quite correct what you say, that the biggest difference between this wave and the first wave was initially last year around this time, if someone had a cough or even just a sore throat, they would show up in hospital, ask to get a test. But we went through a period as a country where the COVID numbers started to calm down, and I think people became a bit complacent. And now we are getting people at very advanced stages of the disease. People are staying at home, they're ignoring ordinary signs that are being publicized on every platform that they could be COVID symptoms. And by the time they show up at our doorstep, they are in a very critical state. That is one big difference that we're seeing now. In terms of what symptoms they come with, I always like to say that COVID is not in any textbook that any medical doctor studied. The disease is new, the disease is a year old, and therefore we learn as we go. And that's one of the hardest things from a personal point and from the professional point of view that we are experiencing. Before you see someone with a certain sign, you might not think it is COVID until now. Once you see that, you add it to your catalog of things you're looking out for. I remember my first patient had just diarrhea, nothing else, no cough, no problem. We tested it was COVID. From that day, I will look out for something like that. Yeah.
So it's literally a case-by-case kind of scenario. I mean, would you say then you are treating symptoms when you go to patient by patient? How do you usually go by the treatment?
I think the first thing is you just have to have a very high index of suspicion. You have to be very alert. And sometimes patients even come with something more obvious. You get a group of people who are in an accident with fractures, and your mind as a doctor, of course, automatically rushes to the most obvious injury they have, which is a fracture. But with time, you start realizing this patient also had other things, and before then, you might even have infected yourself. Therefore, it's just being very alert, being very cautious, and whatever the patient presents with, it's what you deal with. There is really no rigidity around this could not be COVID. Anything could be COVID at this point, and that's how we just deal with every single patient we have to attend to.
Right. Dr. Rowena, we touched on this briefly earlier in terms of, the issue of oxygen, the issue of ICU beds. But, when COVID hit, no one really had, as Dr. Bill said, a playbook on how to respond adequately. But how exposed were we? And a year on, what are you seeing in terms of the gaps that still exist, at least at the county level?
Thank you, Victoria. I think we've tried as a country. One thing that COVID has taught us is even the best healthcare system in the world was not prepared for COVID. You can never be prepared enough or too prepared for such an outbreak. Lessons we've learned is there has to be a different view of how we view the healthcare system, how we channel the resources in the healthcare system, how do we allocate it. Do you want to focus more on public health? That's an area that I know has been quite under-resourced, yet it has come out strongly, including in emphasizing on the measures that we're putting across to prevent spread. We also need to look at how do we, when we say we are equipping hospitals, we're equipping facilities, are we equipping these facilities in case of the next outbreak? Are we looking at a health system and saying it's resilient because it has Muranga has 200 beds? Is that your definition of a resilient system, or is a resilient system one that can adjust if an outbreak happens? if there's a pandemic, an unforeseen pandemic, because you also don't want to spend to overspend on solutions. For example, setting up so many isolation centers that you might not use in the next 20 years. But do you want to strengthen primary healthcare? Yes. Do you want to strengthen health-seeking behavior amongst Kenyans? Yes. That's where you put your resources. So we need to look at how we are allocating resources as a country in healthcare and look at it holistically, look at healthcare financing, look at how in next time, in case of a pandemic, how can NHIF cover everyone who is affected, whether you're a well-off person, whether you're private, public. How can we merge different stakeholders and merge public and private in emergencies so that we have one whole efficient system? I think that's the biggest lesson that I've taken away from health, how COVID has exposed inadequacies in health. Those are the factors that we need to start looking at seriously.
Right, and that's the public health dilemma at hand. You know, do you respond to the scenario right in front of you, or do you brace for the future with investments in terms of equipment and personnel? But, you know, as we speak now, we know the third wave is coming. The peak hasn't hit yet, but it is coming. So how would you say, for instance, you know, your sub-county is preparing in terms of PPEs, beds, and other equipment, and personnel as well? You know, we know there's a huge shortage when it comes to healthcare workers.
I think the issue of human resource for health it's about time like we stopped dancing around it and actually address the issue of having a health service commission. This issue of having each county having to recruit healthcare workers to respond to an emergency individually is not working. So we can't recruit fast enough and we can't manage fast enough if we don't put these measures in place by having a body that does that as the county is handling other aspects in the emergency that they need to handle. But one strategy that we are using in Kangema is we have a very strong multi-sectorial response team. I work with the police, the security team, I work with the legal system, I work with the sub-county administration, I work with the community health volunteers and workers, and we actually even involve village elders. We sit in meetings with them and religious bodies because we understand the value and impact they have in relaying messages on the ground and improving health-seeking behavior. Because we cannot have 20 ICU beds tomorrow in Kangema. It cannot happen. We don't have enough resources for that. So we have to really strengthen healthcare at the grassroots, and that's the strategy we're using, bottom up.
Right. I mean, do you feel that has kind of frustrated how resources trickle down? Does it need to go back to the national level, for instance, in terms of how health is disseminated in this country?
What I think there needs to be better synergy and communication. Let me give an example. Having this vaccine distribution being handled from Ministry of Health going down well laid out plan has actually gotten the vaccines to the grassroots healthcare workers pretty fast. This has shown us how much this healthcare system can get better if there's better collaboration between the county governments and the national governments. Fragmenting the system into 47 different parts needs a lot of coordination and seamless communication and transparency, both from county to Ministry of Health to the county. So in terms of policy and whether healthcare should go back to the national system, that's a discussion that it's a really deep discussion that probably needs to be looked into further, because it wasn't always as glorious as well when it was in the national system. So what lessons can we learn from both ways? Have we brought healthcare closer home? True. Is there misappropriation of funds and resources? True as well. So maybe there needs to be a hybrid and a good balance and better regulation and governance in that issue.
Right. Let me bring Dr. Bill in here, because I see a lot of questions of people asking, so when do I actually make my way to the hospital if I'm going through symptoms, right? We talked about earlier how people wait until it's too late, but at times hospitalization is not necessarily required if someone contracts COVID-19. So what signs should they look out for, and at what point do they actually go to hospital for treatment?
The best time to go to hospital for treatment is the first time you feel you're not okay. The beauty of most people is you know your body, you know how you feel, and you know when something is off. For example, if you, in all your life, you've never lost your sense of smell, and now all of a sudden you cannot smell something, that should tell you there's something off. And that's the right time to contact the healthcare system in whatever capacity, even if it is just going to an outpatient clinic, visiting a hospital, or talking to a doctor if it is possible to get to a doctor. Waiting too long to find out might be the most critical mistake you make. And if you were to think about it that way, as soon as you know there's something off, just contact the healthcare system in whatever capacity you do.
And let's pivot a bit to now focusing on you as a doctor. You know, you're still human beings. Yes, you're professionals. But when you think about the doctor-patient relationship that develops over time, your main goal is to ensure that this person leaves and leaves healthy. But now, you know, with how this disease has ravaged the country, you find it ends in death. And I remember seeing a tweet from an Italian doctor early on when the pandemic had first hit, and they said, you know, death for me is failure, because my job is to ensure that someone leaves healthy. You know, what mental toll has this experience taken on you and your colleagues?
I think the mental toll is something that we will probably have to sit down once we get beyond this pandemic to just discuss. And it takes very many different forms. One of them is the Italian doctor says, when you are the person between this person's life and going back home to see their loved ones, and you are not seeing them doing well, deteriorating every day, and well, unfortunately maybe they succumb, and the next day you have such a similar experience, with time it starts wearing you down. You start feeling like you're fighting a fight that might not be one that you're suited or capable to fight, and that's an example of the kind of mental toll it takes on you. Another big aspect of it that nobody ever seems to talk about is the aspect of isolation. For example, I as a frontline worker have to live alone. I have to go home, picked by an ambulance in the morning, because you don't want to go home and if you pick the disease from hospital, you don't want to go and infect other loved ones out there. And therefore, initially we thought this would have been a few months thing, but then once we're looking at it now, we're thinking it could be a few years thing. And therefore, such a mental toll, as I said earlier, is something we might have to sit down and revisit. Another thing is just purely the simple F word, which is fear. Last year, we lost a colleague of ours, Dr. Mugusu, I think you remember. And he was a friend of mine right from medical school. And when you lose someone as young and someone you could see yourself in and you have similar goals, anybody would be scared. And therefore, working in the midst of fear and anxiety, and you still have to be the one to do it because these people depend on you. These people are looking up to you to be the person to help them. That's also something that also takes its toll on you slowly, and you start realizing it with time. Initially not so much, but with time you start picking up on a few things that on how you are starting to respond to it. Yeah.
Right. You mentioned that you probably will unpack a lot of what this mental stress and trauma will do in terms of the damage. But I'm curious, especially if you're in isolation, are you talking to anyone? Is there any psychosocial support that health workers are getting as they go through this process and not waiting, until this pandemic subsides, which will take a while?
Yeah, actually, this is something that I would commend the Ministry of Health for doing. They thought about it very early on in the pandemic, whereby they set a psychosocial support center and structure where anybody at the front line, literally at the front line, could reach them and could have maybe a session, and they could assess and maybe see whether you are capable of going on, whether you're capable of tolerating the loss, the struggle, the fear. And that's something that I have to give a lot of credit where credit is due. But I think most of the psychosocial support just comes from your colleagues, the nurses you work with, everybody who's the multidisciplinary team you work with, from the nutritionist to the physiotherapist to the critical care intensivist personnel in the hospital. Every day you just have to motivate each other. You have to look each other in the eye and just, it's the way we usually back in Nyeri talk to each other like we are a battalion or a platoon of soldiers, and every day we go in, we have to come out, all of us. And that's probably the most psychosocial support that I personally get, and a lot of us rely on from day to day.
You know, Dr. Rowena, Dr. Bill has just equated this to a battle or a war. And in part, defending or making sure that your soldiers are protected, in this case, is a vaccine. You know, how has the rollout been? You know, earlier on we saw a bit of skepticism among healthcare workers when it came to uptake of the vaccine. How have, you know, the advocacy programs been going in ensuring that it's okay, it works, and they should get it?
We've done a lot of work with Kenya Medical Association and also with the counties and Ministry of Health to advocate for uptake, especially in this first phase of the target groups. Initially, yes, there was a lot of, and there still is a bit of vaccine hesitancy. I think when people are sensitized, and this is one thing I always ensure I do before we vaccinate a group of people, a cohort, we do a lot of sensitization. So answering questions, clearing the air about demystifying myths that they see on social media. There's also the aspect of COVID fatigue amongst healthcare workers. Sometimes when you see or hear something so much, you become kind of used to it, and not in a good way. So that initial fear that was there, people kind of just got accustomed to it, working in that environment. But we're really working hard sensitizing healthcare workers, and the uptake is going up. I think the actual population that we are now having problem targeting in the first phase is the people aged over 58. There needs to be more advocacy on that. The vaccine rollout, I say, went pretty fast. I think I alluded to that earlier, and I'd like to commend the Ministry of Health on that, acquiring the AstraZeneca vaccine and deploying it as fast as possible to the counties. That was went pretty efficiently. A few delays in logistics, having some days where there's runouts, especially following the last presidential announcement, and which shows you the effect of leadership and how people believe in leaders when we talk about something. So the uptake really went quite fast at that moment. So far so good. We could do better, more sensitization, more advocacy. Billboards should be all over encouraging. We should be getting SMSs, but so far so good. Yeah.
Dr. Bill, I need to go back to the issue of treatment, just in terms of what doctors are doing now. You mentioned how dynamic this situation is. You have to go on a case-by-case basis. And the reason I'm asking this is because, we heard Raila Odinga talk about a mixture of medicines or concoction that he was given while he was being treated. Are doctors having to, what are they relying on now in terms of the drugs or the treatments that they're employing to treat patients, COVID-19 patients?
That's a very, very, very good question, because unfortunately in the middle of this pandemic, we also have an infodemic where there's too much information out there. And unfortunately, any person can have their own view, but you would not want your doctor to be treating you based on their personal views. So we try to really educate ourselves and keep each other updated on what is working, what is not working. Remember, this is a disease we are studying in real time. Anything we are giving has to be proven within this period. There's no years of study, no years of research that we can rely on. Therefore, as my colleague Dr. Rowena has done, the first time we actually met was in Kenyatta, and we go for regular trainings. We try to see what is working, and we have networked amongst ourselves as frontline workers, and sometimes we just exchange notes. Sometimes it's as simple as a conversation where you hear a colleague telling you, I personally give them this and they improve. And with time you pick it up and different institutions pick it up. But the most important thing is to try and rely on actual science to treat patients, not a lot of information that flies around from the internet, from different sources, some that are not proven, some that are in the middle of research. And you always want, as we took our oath, you always want to do what's best for the patient.
Just as we wrap up this discussion, Dr. Rowena, I have to ask, what does the future or a COVID-19, post-COVID-19 world look like for the medical fraternity? What does emergency response and medicine look like after having gone through a pandemic like this?
I think there's more emphasis on risk management. It's been brought to the front that we need to be more prepared in terms of systems, as I talked about earlier. A lot of emphasis actually on the mental health of doctors, healthcare workers in general. I think we talked about it earlier. This has been an issue that has been there for years. COVID has brought out that burnout, has brought out the weariness and the stress that comes with undertaking your duties every day as a medic. So I think there's more emphasis on the mental health of healthcare workers. Hopefully there's going to be more emphasis on the welfare of healthcare workers. There's going to be more emphasis on efficiency of a system, more than just planting equipment here and there without looking at it holistically in terms of how do you support the running or sustainability of that service offered. So I hope that this will trigger a lot of policy change, a lot of involvement of all stakeholders, legislation in how a country prepares itself for a pandemic in the healthcare system.
Dr. Bill, let me finish with you. I remember we had this conversation a bit earlier on. If you can remember, there was a point where every Wednesday there would be applause for frontline healthcare workers. That died down, and there was a lot of chatter around, CLAPs don't buy PPEs and they don't equip ICU facilities. What do doctors need now, especially as you're bracing for a third wave?
I think what doctors would really need, other than applause, because you cannot negate the effect of applause every Wednesday. I think this is the time we need politicians and the bureaucrats to listen to the scientists and follow what is best practice across the world. As it pertains to doctors, I think what we need in hospitals should now be supplied with top priority status. As Dr. Rowena has said, the equipment, the drugs, the infrastructure around hospitals. This would be the perfect time to work on our healthcare system as a country. If our pandemic cannot bring us to the point of concentrating on our healthcare system, I really wonder what would make us focus on it. The other thing is the healthcare is the health of our healthcare workers. A lot of the issues we discuss and all those things, whenever there's no pandemic, this is a time that those small stresses exert a big influence on whoever is treating you. And Victoria, I'm sure if you go to hospitals, you'd not want your doctor to be worried about small things such as fee, such as delayed payments and the rest. Therefore, the health of the healthcare workers right now should also be something that should not be on the mind of the doctor treating you. It should not be on the mind of the person who is standing between you and your health. We could get that and the support and the goodwill that we get from everyday Kenyans. I usually get so happy whenever you're walking somewhere, especially like in Nyeri, and someone stops you and just says thank you. Like, you could have chosen to not be a doctor at this time and go do any other thing, but you still persevere. That still helps. But I think we need everything to work together, especially during this period.
Couldn't have said it better myself. Thank you so much, Dr. Bill, Dr. Rowena, our heroes in this COVID-19 fight. Appreciate your insights as well. Invaluable, especially at a time like this. As you said, Dr. Bill, we are also going through an infodemic. The right information can save lives. And that does it for Citizen Weekend. Thank you so much for watching. I'm Victoria Rubadiri. Our sign language interpreter tonight has been Wilson Mushora. Stay tuned, though. One Love coming up next. Good night.